This is a presentation on cerebral palsy in children by Melanie Alaman, Carrie Amesqua, Karen Garcia, and Christina Hansen. What is cerebral palsy? Cerebral palsy is what we call CP. It is a group of disorders that affect a person's ability to move and maintain balance and posture. CP is the most common motor disability in childhood. About 1 in 323 children have been identified with CP according to estimates from CDC's Autism and Developmental Disabilities Monitoring Network. Cerebral means having to do with the brain, and palsy means weakness or problems with using muscles. CP is caused by abnormal brain development or damage to the developing brain that affects a person's ability to control their muscles. Symptoms vary from person to person, and CP is more common among girls than boys. A person with severe CP might need specific equipment to walk, or they might not be able to walk at all and need lifelong care. CP does not get worse over time, though the exact symptoms can change over a person's lifetime. All people with CP have problems with movement and posture. According to the CDC, about 50% to 60% of children can walk independently. What causes cerebral palsy? Cerebral palsy is caused by abnormal development or damage to the developing brain. The damage to the brain that causes it can happen before birth, during birth, within a month after birth, or during the first year of a child's life, which is the time that the brain is still developing. The majority of CP is congenital. Congenital CP is when the brain damage occurred before or during birth. A small percentage of CP is caused by brain damage that happens more than 28 days after birth, which is acquired CP. Acquired CP can be caused by a brain infection such as meningitis or suffering a serious head injury. Specific cause of most children is unknown, and CP is typically diagnosed during the first or second year of life. But if a child has mild symptoms, it is sometimes difficult to make a diagnosis until the child is a few years older. There is no cure for CP, but supportive treatments, medications, and surgery can help many individuals improve their motor skills and the ability to communicate with the world. There are 4 main types of cerebral palsy, but how are they each classified? The specific type of cerebral palsy is determined by the extent, type, and location of a child's abnormalities. Doctors classify CP by the main type of movement disorder involved, which are based on whether a child presents with stiff muscles, which is spasticity, uncontrollable movements, which is dyskinesia, or poor balance and coordination, which is ataxia. The 4 types of cerebral palsy are spastic cerebral palsy, which is the most common type of CP, dyskinetic cerebral palsy, ataxic cerebral palsy, and mixed cerebral palsy. We will now go into detail about each kind of CP. Spastic cerebral palsy is again the most common CP. Spastic CP affects 80% of people with CP. People with spastic CP have increased muscle tone. This means their muscles are stiff, and as a result, their movement can be uncoordinated. There are 3 types of spastic CP that are classified by what parts of the body are affected. Spastic diplegia, which is muscle stiffness and is mainly in the legs. Spastic hemiplegia, which affects only one side of a person's body. The arms are usually more affected than the legs. And spastic quadriplegia, which is the most severe form. It affects all 4 limbs, the trunk, and the face. And people with this form usually cannot walk and often have other developmental disabilities, such as intellectual disability. They have seizures and have problems with vision, hearing, and speech. The second kind of cerebral palsy is dyskinetic cerebral palsy. This is when a person has problems controlling the movement of their hands, arms, feet, and legs, making it difficult for them to sit or walk. The movements of these individuals can be slow, writhing, or rapid and jerky. Sometimes the face and tongue are affected, and the individual will have a hard time sucking, swallowing, and talking. The third type of cerebral palsy is ataxic CP. This is when a person has problems with balance and coordination. They might have a hard time with quick movements and movements that require a lot of control, such as writing. And the 4th type of cerebral palsy is mixed cerebral palsy. Some people have symptoms of more than one type of CP. The most common type of mixed CP is spastic dyskinetic CP. What are other conditions associated with CP? Many individuals with CP have other conditions that are associated with their CP, such as intellectual disability, seizures, problems with vision, hearing, speech, changes in the spine such as scoliosis, abnormal sensations and perceptions, learning difficulties, malnutrition, and inactivity. So what is the language profile of children with CP? A third of children with cerebral palsy have speech and language disorders, such as difficulty forming words and speaking clearly. Their speech impairs communication and is often interpreted as a sign of cognitive impairment. This can be very frustrating to children with CP, especially the majority who have average to above average intelligence. CP also affects their ability to coordinate the muscles around their mouth and tongue that are needed for speech. The coordinated breathing that is needed to support speech can also be affected. The degree of spasticity differs. Spasticity affects how they use their mouth and face muscles to talk and eat. Some people with cerebral palsy may not be able to produce any sounds. Others may be able to produce sounds but have difficulty controlling their movement enough to produce speech that is clear and understood by others. 1 in 4 people with CP cannot talk. Some individuals with CP drool because they have poor control of muscles of the throat, mouth, and tongue. Aside from difficulties in their speech production, there are other aspects of language that are affected. They have difficulty using and understanding words, comprehending and formulating linguistic messages, and using appropriate grammar and syntax. In regards to their pragmatic skills, they have difficulty using language for different purpose and following conversational norms. Children with CP experience specific difficulties and language difficulties that can affect their performance in the classroom. They have a difficult time processing particular types of spatial and auditory information. In the classroom, learning can also be affected by difficulties in fine motor and gross motor coordination and communication. Students that have cerebral palsy have to put in more effort into concentrating on their movement for sequence of actions more so than others and tire easily. Their communication challenges of any kind can lead to educational and social isolation and can have detrimental impact on nearly all aspects of development. Most children with CP who have early communication problems will have long-standing and persistent problems with communication as they mature. This finding suggests that treatment should be initiated early for children with CP who show signs of speech or language delay. 3 language assessments that would be appropriate procedures for a child with CP for a comprehensive evaluation to help gain an understanding of the child's abilities in regards to speech and language are the Peabody Picture Vocabulary Test for receptive language, a narrative assessment profile of storytelling for expressive language, and a parent questionnaire, which is an informal assessment. To assess receptive language, the Peabody Picture Vocabulary Test can be used. It is a measure of listening vocabulary. The child is prompted to identify the word they heard by selecting the correct picture from a choice of 4. It is a norm-referenced assessment with a total of 228 test items. This assessment is for the age range of 2 years and 6 months to 90 years. Thus, it is appropriate to use for school-age children, and particularly those with CP, because according to research, receptive vocabulary tends to be impaired in this population. The inability to understand language will affect their ability to express it and therefore affect their overall communication and social interactions with others. The completion time for this test is 10 to 15 minutes and does not require reading or writing. The ability to express oneself via narratives is a skill that is usually developed in the preschool years for typically developing children. This is an important component of communication. Narrative ability is one way to provide a quasi-naturalistic measure of a child's spontaneous language. According to Burrow 2008, story retelling is appropriate for assessing language comprehension in preschool and older school-age children with cognitive abilities. The retelling ability can be assessed via storybooks that have pictures and no written words. For example, the evaluating clinician might consider using the bus story test. It is important that the clinician record the narrative, transcribe it, and analyze it for the amount of information included, the mean sentence length, and number of subordinating clauses. Low BST scores are usually a valid predictor of a language impairment in a child. It is important to note that the clinician may consider alternative tests to conduct a story retelling. The BST is just one example of what it looks like. This test is appropriate for the ages 3 years to 6 years and 11 months and takes 10 minutes to administer. Collaboration with caregivers and input given is important for gathering additional information in regards to the child's strengths and weaknesses. The evaluation SLP should collect this information via parent questionnaire. In the questionnaire, the SLP will collect data on how the caregiver's son or daughter performed on various language skills on a regular basis, if the child understands language spoken in words, sentences, and if they can read words and books. The recommended questionnaire is the Vineland Adaptive Behavior Scale 2nd edition. This questionnaire contains 5 domains, each with 2 to 3 subdomains. The main domains on this questionnaire include communication, daily living skills, socialization, motor skills, and maladaptive behavior. This test takes 20 to 60 minutes to administer and includes a teacher rating form that pertains to the academic functioning. The 3 domain composite scores of daily living, communication, and socialization. There are a few therapy treatments that would be appropriate for someone with CP. 4 of them are augmentative and alternative communication, communication partner instruction, prompt therapy, and neuromuscular electrical stimulation. We will discuss all 4 of these therapies. The first treatment we will discuss is AAC. Because CP can take many forms, augmentative and alternative communication can be used in a variety of ways. The end goal is to support an individual's development of total communication. There are 2 types of AAC that can be utilized: unaided systems, which requires only gestures, body language, facial expressions, and sign language, and also aided systems, which involves low-tech and high-tech devices. These devices range from a pen and paper to speech-generating machines. With AAC, SLP can incorporate individualized language-based therapy. AAC is used to facilitate pragmatic skills such as turn-taking, semantic skills such as a single-word expressive vocabulary, and grammatical skills such as a building syntax. Another therapy is communication partner instruction. Moreover, AAC is also used to train communication partners on how to support an individual's functional communication and expressive language. Communication partners may include peers, family members, educators, and other professionals. Kent Walsh suggests partner instruction should always be an integral part of the AAC assessment and intervention. More information can be found at cerebralpalsyalliance.org about how to approach communication partner training as it relates to an individual's age, type of CP, mobility, arm abilities, communication abilities, type of movement disorder, and intellectual ability. The next therapy is prompt therapy. One of the goals in speech therapy is to address speech intelligibility in order to improve communicative functions and minimize a child's restriction to participate in social and educational opportunities. Work by Hahn supports the finding that individuals with CP present with decreased white matter fibers connecting to the sensory cortex, which can explain why motor speech control is inefficient in these individuals. In other words, sensory feedback that is needed to determine appropriate control, adjustment, and stabilization in speech is impaired. PROMPT, which stands for Prompts for Restructuring Oral Muscular Phonetic Targets, is a tactile kinesthetic treatment strategy that is used to augment sensory information. A trained speech-language pathologist uses their hands to physically show the individual how to move their mouth, jaw, lips, and tongue. The speech mechanism, including respiration, phonation, articulation, and prosody, are assessed and interpreted using the prompt motor speech hierarchy. There are different levels in this therapy. Levels 1 to 2 focus on postural support for speech and the ability to produce sound for 2 to 3 seconds. Levels 3 to 5 focus on training movement patterns of the jaw, lips, and the tongue. Levels 6 and 7 focus on sequencing movement, seeing speech and prosody. According to the Prompt Institute, a therapist's priority is to teach them words that are relevant and functional. The last therapy we will discuss is neuromuscular electrical stimulations. According to ASHA, between 19% and 99% of individuals living with cerebral palsy also present with some degree of oropharyngeal dysphagia. Severity depends on cognitive impairment and decline in gross motor function. The effects of neuromuscular electrical stimulation to treat dysphagia in children with cerebral palsy was studied by Song. In this study, participants were treated with 10 minutes of oral sensory motor treatment, with stimuli presented to the cheeks, chin, lips, tongue, and oral palate using an occupational therapist finger, a vibrating device, and an ice stick. Following this procedure, NMES was initiated. This involved 2 surface electrodes placed over the throat between the jaw and the hyoid, and another 2 placed between the hyoid and the thyroid notch. The electronic stimulation created muscle contractions for 20 minutes. The treatment was applied 2 times per week for 8 weeks. They found that NMES significantly improved function related to the oral phase, including strong lip closure, ability to swallow food without excess loss, ability to sip liquids, ability to swallow liquid without excess loss, and the ability to swallow without cough. Other professionals that can assist a child with CP are physical therapists, occupational therapists, and behavioral therapists. A physical therapist can assist the child with mobility treatment. They plan exercises and activities to improve physical and functional skills. Preventative treatment promotes well-being, fitness, and overall health of the child, and pain management. An occupational therapist assists in sensory awareness, vision therapy, environmental therapy to improve range of motion, flexibility, and development. They support social integration and facilitate improved quality of life. A behavioral therapist assists in finishing tasks, academic success, anxiety reduction, lessening or curing depression, and resolving conflict for the child. Here are the references that we used for this presentation. This concludes our presentation. Thank you so much.